Shepard EM Board Review, Chapter B03, Shock, Recognition, Classification, Resuscitation. You secured the airway, you ran the ventilator, and now the blood pressure is dropping. 3 steps, 4 categories, 1 reassessment loop. Let's go to work. Case 1, 78-year-old woman from a long-term care facility. 2 days of fever, urinary frequency, and increasing confusion. Vital signs, blood pressure 82/48, heart rate 122, respiratory rate 28, temperature 38.9 Celsius, oxygen saturation 91% on room air. On exam, she is sleepy but arousable. Mucous membranes dry, knees mottled, capillary refill 4 seconds. Urinalysis is turbid. Lactate 4.8. The diagnosis is not subtle. The question is what to do first. Fluid, pressors, antibiotics, all 3, and the order matters. The number is low. The question is, what kind of low? Because every category of shock has a different first move. Get the category right and the resuscitation falls into place. Get it wrong and you give fluid to the cardiogenic patient or epinephrine to the bleeder and you make it worse. So, 3 steps, 4 categories. 1 reassessment loop. Step 1, recognize the shock even when the cuff still looks fine. Lactate, base deficit, mottling. Step 2, classify the shock. Distributive, hypovolemic, cardiogenic, obstructive. Step 3, resuscitate by category. Fluid, blood, pressors, or decompression. Then reassess every 15 minutes, because shock changes faster than your treatment plan. By the end of the next 40 minutes, you will own all 3. Case 2, 64-year-old man with 2 hours of crushing substernal chest pain radiating to his jaw. Vital signs, blood pressure 76/50, heart rate 108, respiratory rate 26, oxygen saturation 89% on a non-rebreather. On exam, jugular venous distension, rails to the apices, cool, clammy extremities. EKG shows anterior ST elevations in leads V1 through V4. Troponin is pending. Cardiogenic shock from anterior STEMI. The cath lab is 45 minutes away. Same question. Fluid, pressors, what goes first? Case 3, 22-year-old woman, dinner at a restaurant, peanut sauce in the curry. 2 minutes after the first bite. Diffuse urticaria, swollen lips, hoarse voice, audible stridor. Vital signs, blood pressure 78/40, heart rate 132, respiratory rate 30, oxygen saturation 92%. She is sitting forward, anxious, struggling to breathe. The diagnosis is obvious. The intervention is even more obvious, but we still see it delayed in real EDs every day. What goes first, and where? What shock actually is. Shock is inadequate tissue oxygen delivery, not low blood pressure. Low blood pressure is a late finding. The patient is in shock the moment their cells stop getting enough oxygen, often hours before the cuff catches up. Oxygen delivery has 3 levers: cardiac output, hemoglobin, and oxygen saturation. Drop any of the 3 and you have shock. The mitochondria notice first. They start producing lactate. The blood pressure catches up last. That is the framework. Treat the delivery, not the number. Mean arterial pressure, the number we actually care about. Mean arterial pressure equals diastolic plus 1/3 of pulse pressure. Roughly 2/3 diastolic, 1/3 systolic. The cells perfuse off MAP, not off systolic. The target in nearly every shock state is a MAP at or above 65. Sepsis PAM showed no benefit to a higher MAP target of 80 to 85 in unselected septic shock. Targeting higher just exposes the patient to more pressure without better outcomes. So, 65, unless you have a specific patient-level reason to deviate. Shock can be normotensive. This is the highest yield concept in the entire lecture. A lactate above 4. A base deficit more negative than -4. A urine output under 0.5 milliliter per kilogram per hour. Any one of these, even with a normal cuff, is shock. The young trauma patient with a heart rate of 120 and a normal blood pressure is compensating. They will crash. The septic patient on home beta blockers will not mount the tachycardia, but they are still in shock. Treat the physiology. Do not wait for the number. Empirical criteria for shock, straight from Rosen's box 3.2. Ill appearance or altered mental status. Heart rate over 100. Respiratory rate over 20 or arterial CO2 under 32. Base deficit more negative than -4 or lactate over 4. Urine output under 0.5 milliliter per kilogram per hour. Hypotension lasting more than 30 minutes. The teaching is that the majority of these criteria should be met, regardless of cause. The boards love this list. Memorize the 6, look for 4 or more. Bedside markers. What to look at first. Skin, mottled, cool, delayed capillary refill. Mucous membranes, dry. Mental status, confused, agitated, drowsy. Pulse, weak, thready, fast. Breathing, rapid, shallow. You can see shock from the doorway. The doorway diagnosis is real. By the time you have the cuff on the arm, you should already know the patient is in shock. The labs are confirmation. The exam is the trigger. Capillary refill and the knee mottling score. Press the fingertip. Release, count to 3. Anything over 3 seconds is abnormal. Look at the knees. Mottling, the lacy bluish marbled pattern over the patella, is scored 0 to 5 based on how far up the thigh it extends. A score over 2 predicts mortality independently of every other variable. The Andromeda Shock trial, capillary refill guided resuscitation matched lactate guided resuscitation, with a signal toward less organ dysfunction. The thumb beats the lab. Don't underestimate the bedside exam. Lactate. What it means and what it does not. A lactate over 2 is concerning. Over 4 is critical and an independent predictor of mortality. The trend matters as much as the absolute number. A downward trend during resuscitation is good. A clearance of 10 to 20% over 2 hours is the standard target. A flat or rising lactate despite resuscitation is bad. Back to case 1, our septic elderly woman with a lactate of 4.8. That is shock. But remember, lactate is not just anaerobic metabolism. Sepsis itself elevates it. Beta agonists like albuterol elevate it. Metformin, seizures, post-arrest, even liver dysfunction. Use the number in context. 4 categories of shock. Distributive, vasoplegia. The pipes have dilated. Sepsis, anaphylaxis, neurogenic, adrenal crisis. Hypovolemic, volume loss. Hemorrhage, GI losses, burns, third spacing. Cardiogenic, pump failure. MI, decompensated heart failure, myocarditis, dysrhythmia, valvular catastrophe. Obstructive, outflow blocked. Pulmonary embolism, cardiac tamponade, tension pneumothorax. 4 categories. Every undifferentiated shock patient lives in one of them, sometimes 2. The category drives the first move. The Hemodynamic Profile table. This is the table the boards build questions around. 4 columns, distributive, hypovolemic, cardiogenic, obstructive. 4 rows, systemic vascular resistance, cardiac output, central venous pressure, mixed venous oxygen saturation, distributive shock, systemic vascular resistance down, cardiac output up, CVP down, SVO too high. The patient is warm and flushed. Hypovolemic shock, systemic vascular resistance up, cardiac output down, CVP down, SVO too low. The tank is empty. Cardiogenic shock, systemic vascular resistance up, cardiac output down, CVP up, SVO too low. The pump has failed. Obstructive shock, systemic vascular resistance up, cardiac output down, CVP up, SVO too low. The outflow is blocked. Memorize this table. Distributive shock, and sepsis is the headliner. Septic shock starts with massive vasoplegia. Systemic vascular resistance drops. Cardiac output is usually elevated early, the so-called warm shock phase. Then capillary leak develops, intravascular volume drops into the third space, and relative hypovolemia compounds the picture. Within hours, myocardial depression emerges, even in patients with completely normal baseline cardiac function. Inflammatory cytokines and nitric oxide are the mediators. Mortality is still over 40%. Back to case 1, our septic elderly woman. She lives in this physiology. Norepinephrine territory. Anaphylactic and neurogenic distributive shock. Anaphylactic shock, mast cell degranulation, vasodilation, plus bronchospasm, plus capillary leak. The treatment is intramuscular epinephrine in the anterolateral thigh, not IV fluid first. Fluid does not fix vasoplegia and bronchospasm. Epinephrine does. The board trap is exactly that, picking a fluid bolus or an antihistamine over IM epinephrine. Neurogenic shock, spinal cord injury, sympathetic outflow disrupted, vasodilation often paired with bradycardia. Norepinephrine first, atropine for the bradycardia. Back to case 3, our peanut anaphylaxis patient. Where is the epinephrine? In her thigh, in the next 60 seconds. Hypovolemic and hemorrhagic shock, hypovolemic, gastrointestinal losses, third spacing, burns, replace with crystalloid, hemorrhagic, bleeding, replace with blood. The teaching point, acidemia precedes hypotension. Base deficit becomes more negative early, sometimes before any vital sign changes. The pulse pressure narrows before the systolic drops. The young trauma patient with a blood pressure of 100/90 and a heart rate of 120 looks stable and is 1 bolus away from circulatory collapse. Treat the trend, not the snapshot. Cardiogenic and obstructive shock. Cardiogenic, pump failure. The big 4, Anterior MI, decompensated heart failure, myocarditis, sustained dysrhythmia. Mortality over 40%, same neighborhood as septic shock. Obstructive, outflow blocked. Pulmonary embolism with right heart strain. Cardiac tamponade with low pressure right heart filling. Tension pneumothorax with mediastinal shift. These are the fluid resuscitator's nightmare. They don't need volume, they need decompression. Bedside ultrasound separates cardiogenic from obstructive in about 90 seconds. Back to case 2. Our anterior STEMI patient. He lives here. The rush exam. Rapid ultrasound for shock and hypotension. 5 windows. The pump, the heart, the tank, the inferior vena cava, plus Morrison's pouch and the lungs. The pipes, the abdominal aorta, plus a quick anterior chest for pneumothorax. Heart, IVC, Morrison's and lung. Aorta. Pneumothorax. 5 probe positions. Under 5 minutes. The literature is clear. A systematic POCUS protocol changes the working diagnosis in undifferentiated shock about 1/3 of the time. Make it routine for every shock patient in your ED. The heart window. 3 findings, 3 categories. A hyperdynamic left ventricle. The walls almost touch at end systole, sometimes called kissing walls. Distributive shock. Sepsis until proven otherwise. A poor left ventricle. Dilated, hypocontractile, slow squeeze. Cardiogenic shock. A right ventricle that is bigger than the left, with a D-shaped septum bulging into the LV, right ventricular strain. Obstructive shock. Massive pulmonary embolism until proven otherwise. Back to case 1, our septic elderly woman would show a hyperdynamic kissing walls LV. That is your visual confirmation of distributive shock. The IVC window. Subxiphoid view, fan to the right of the aorta. An IVC under 1.5 centimeters that collapses fully with inspiration. Volume responsive. Give fluid. An IVC over 2.5 centimeters that barely collapses. Volume tolerant or already volume overloaded. Be very careful with more fluid. Pair the IVC with the heart window. IVC alone is not the answer, particularly in patients on positive pressure ventilation where the dynamics flip. Back to case 2, our anterior STEMI patient would show a plethoric IVC and a poor LV. That is the imaging signature of cardiogenic shock and a warning sign against the reflexive fluid bolus. Morrison's pouch, the aorta, and the anterior chest. Morrison's pouch, the space between the liver and the right kidney. Free fluid suggests intra-abdominal hemorrhage. Look at the lungs too. Diffuse B lines suggest pulmonary edema or pneumonia. The abdominal aorta, dilated above 3 centimeters, suggests aneurysm, and in a shocky patient, suggests rupture. The anterior chest, absence of lung sliding, suggests pneumothorax, but is not specific in the post-intubation patient or the patient with bullous disease. Take the whole exam. Synthesize all 5 windows. Do not anchor on any single finding. Balanced crystalloid is the new default. Lactated ringers, plasma light. These are balanced. Chloride content matches plasma. Normal saline has way too much chloride. Large volumes cause a hyperchloremic metabolic acidosis and an acute kidney injury signal. The SMART trial and the SALT ED trial both showed a composite benefit favoring balanced fluids, fewer kidney injuries, fewer renal replacement therapies, lower mortality in the sickest subgroups. So, for the shock patient who needs crystalloid, reach for lactated ringers. Back to case 1, our septic patient. Balanced crystalloid, not normal saline. The exception is massive trauma transfusion, where normal saline is acceptable due to compatibility with blood products. Cardiogenic shock does not get the 30 milliliters per kilogram bolus. This is one of the most important board pearls in resuscitation medicine. The cardiogenic shock patient with pulmonary edema cannot handle that volume. You will drown them. Small fluid challenges only, 250 to 500 milliliters, and only if you believe they are preload deficient. Otherwise, norepinephrine first to support the MAP. Dobutamine added for inotropic support. Activate the cath lab, reverse the insult. Back to case 2, our anterior STEMI in cardiogenic shock. No big bolus, pressors, cath lab, that is the order. Anaphylaxis, epinephrine first, fluid second. Intramuscular epinephrine in the anterolateral thigh. Adult dose, 0.3 to 0.5 milligrams of the 1 to 1,000 concentration. Repeat every 5 to 15 minutes if symptoms persist. Fluid comes after. IV epinephrine infusion is reserved for refractory shock. Start at 0.05 to 0.2 micrograms per kilogram per minute. Do not delay IM epinephrine while you debate IV access. The thigh is fast, reliable, and forgiving. Back to case 3, our peanut patient. EM epinephrine in her thigh right now. The 30 milliliters per kilogram debate. Surviving sepsis 2021. recommends 30 milliliters per kilogram of balanced crystalloid in the first 3 hours of septic shock. That is the headline. The reality, not everyone needs 30. The Clovers trial and the Classic trial both compared restrictive fluid strategies to standard care in septic shock. Both were essentially neutral on mortality. The takeaway is not skip the fluid. It is individualize after reassessment. 30 milliliters per kilogram is a starting point, not a ceiling, and not a mandate for every patient. The volume-overloaded 80-year-old with diastolic heart failure does not need the same starting volume as the previously healthy 30-year-old. Dynamic fluid responsiveness. The passive leg raise. The best volume challenge that is not a fluid bolus. Lay the patient flat. Raise both legs to 45 degrees. Hold for 60 seconds. Measure stroke volume or cardiac output by POCUS, by arterial line, or by end-tidal CO2 trend. A rise of 10 to 15%. The patient is fluid responsive. Give the fluid. No rise, no more fluid. Reversible, repeatable, no wasted volume. IVC variation and pulse pressure variation are the other dynamic measures, but they require positive pressure ventilation and sinus rhythm. The passive leg raise works in everyone. When to stop fluid. 2 or 3 500 milliliter boluses without hemodynamic improvement. A rising plateau pressure, or a new oxygen requirement on the ventilator, a plethoric IVC, new B lines on lung ultrasound, a falling stroke volume on the passive leg raise, you have hit the top of the Frank-Starling curve. Time to switch to pressors. The cardinal sin in shock resuscitation is repeated bolusing a non-responder. Each unnecessary liter is more pulmonary edema, more abdominal compartment pressure, more endothelial damage. Reassess after every bolus. Vasopressor selection by shock type. Septic shock, norepinephrine first. Cardiogenic shock, norepinephrine plus dobutamine. Anaphylactic shock, epinephrine. Neurogenic shock, norepinephrine. Hemorrhagic shock, blood products, not pressors. Pressors and hemorrhage actually increase mortality because they mask the underlying problem. Pressors are a bridge to source control, never a destination. The treatment of shock is not max the pressors. The treatment of shock is reversing the cause while pressors hold the perfusion line. Back to case 1, our septic elderly woman. Norepinephrine, right now. Norepinephrine, the workhorse. Predominantly alpha-1 vasoconstriction with some mild beta-1 anotropy. First line for septic shock. First line for cardiogenic shock. First line for neurogenic shock. Start at 0.05 micrograms per kilogram per minute. For most adults, that is 3 to 5 micrograms per minute. Titrate up every 3 to 5 minutes to a MAP target of 65. There is no defined maximum dose, but if you are over 0.25 micrograms per kilogram per minute, it is time to add a second pressor and to think about the cause. Back to case 2, our anterior STEMI patient. Norepinephrine first, dobutamine soon after. Epinephrine, the anaphylaxis drug, the cardiac arrest drug, the refractory shock drug, anaphylaxis, intramuscular, 0.3 to 0.5 milligrams of the 1 to 1,000 concentration in the anterolateral thigh. Refractory shock, IV infusion at 0.05 to 0.2 micrograms per kilogram per minute. Pediatric anaphylaxis, 0.01 milligrams per kilogram intramuscularly. Cardiac arrest, 1 milligram of the 1 to 10,000 concentration every 3 to 5 minutes during the code. Different concentrations for different routes. Read the vial. Push dose epinephrine, 10 to 20 micrograms IV, is the bridge dose for the crashing patient. Back to case 3, our peanut anaphylaxis, the thigh. Now. Vasopressin, the second pressor. Fixed dose, 0.03 to 0.04 units per minute. Not titrated. Norepinephrine sparing. It lets you bring the norepinephrine dose down. Add it when the norepinephrine requirement climbs above approximately 0.25 micrograms per kilogram per minute. Not a monotherapy first-line agent. Particularly useful in vasoplegic shock after cardiac surgery and in refractory septic shock. The Vanish trial, vasopressin versus norepinephrine in septic shock as the initial agent, showed less acute kidney injury but no mortality benefit. The role is adjunctive. Dobutamine, the pure inotrope, beta-1 agonist, increases cardiac contractility, increases cardiac output, some mild beta-2 activity, which means it can drop the blood pressure. Indications: cardiogenic shock where cardiac output remains low despite an adequate MAP on norepinephrine. Septic shock where myocardial depression keeps the lactate up despite adequate volume and norepinephrine. Dose, 2 to 20 micrograms per kilogram per minute, titrated every 5 to 10 minutes. Watch the blood pressure as you titrate up. If the MAP drops, you may need to push the norepinephrine higher to keep up. Phenylephrine, pure alpha, no beta activity. Useful when tachycardia dysrhythmia limits the use of norepinephrine. For example, a patient with atrial fibrillation with rapid ventricular response whose heart rate accelerates with norepinephrine. Push dose form, 50 to 200 micrograms IV, drawn up as 100 micrograms per milliliter solution. Infusion, 0.5 to 5 micrograms per kilogram per minute. The classic catch, reflex bradycardia can drop cardiac output, especially in patients who depend on heart rate for stroke volume. Useful drug, narrow indication. Dopamine, the wrong answer in septic shock. The SOAP-2 trial, dopamine versus norepinephrine as the first-line agent in shock. Overall mortality, no significant difference, but significantly more dysrhythmias in the dopamine arm, and a clear mortality signal in the cardiogenic shock subgroup favoring norepinephrine. Since then, dopamine has fallen out of favor in adult shock. If you see dopamine on a board exam stem as a vasopressor choice for septic or cardiogenic shock, it is the trap answer. Choose norepinephrine. There are very few situations in adult emergency medicine where dopamine is the right answer. Peripheral vasopressors, myth and reality. The old teaching was never run a pressor through a peripheral IV. The current evidence, norepinephrine and other vasopressors can be started safely peripherally, while central access is being secured. The conditions matter, proximal IV, antecubital fossa, or above. A patent line with a good flush. Bedside monitoring every 15 minutes for extravasation, an extravasation kit with phentolamine at the bedside. Time limited, a bridge to central access within 12 to 24 hours. Multiple ED cohorts have shown safety. Do not delay pressor initiation while waiting for the central line. Mechanical circulatory support, the escalation ladder. Intra-aortic balloon pump, afterload reduction, modest improvement in coronary perfusion. IABP shock, 2, showed no mortality benefit in the routine cardiogenic shock population. Still used selectively. IMP-ELA, a percutaneous left ventricular assist device, pumps blood from the LV to the aorta. The Danger shock trial recently signaled a mortality benefit in selected anterior MI cardiogenic shock patients. Veno-arterial ECMO, full cardiopulmonary support. Bridge to recovery, to transplant, or to durable LV-ed. Reserved for the most refractory cases. Back to case 2, our anterior STEMI in cardiogenic shock. If norepinephrine plus dobutamine plus revascularization is not enough, this is the ladder. REBOA, resuscitative endovascular balloon, occlusion of the aorta. The indication, torso hemorrhage distal to the renal arteries, in a patient who is not responding to transfusion. Penetrating or blunt trauma, a bridge to the operating room or to interventional radiology. Femoral arterial access, balloon inflated in either zone 1 above the celiac trunk or zone 3 below the renal arteries, depending on the bleeding source. Requires trained operators. Not universally available. The joint ACS cot and ACEP statement defines its limited but real role. Do not pull the trigger on REBOA when the patient would do better with rapid massive transfusion. Source control. The cure. Pressors and fluid keep the patient alive while you fix the underlying cause. Hemorrhage, surgical control, endovascular control, embolization. Sepsis, drain the abscess, debride the necrotic tissue, remove the indwelling line, deliver the placenta. Cardiac tamponade, pericardiocentesis, tension pneumothorax, finger thoracostomy, or needle decompression. Massive pulmonary embolism, systemic thrombolysis or catheter-directed therapy. Cardiogenic shock from MI, percutaneous coronary intervention. Find the source. Fix the source. The pressors and the fluid are a bridge. Pediatric shock, the single most important teaching point. Pediatric patients stay normotensive until they decompensate. The blood pressure looks fine right up until it doesn't. Tachycardia is the earliest sign. Capillary refill prolonged over 3 seconds. Cool extremities, mottled skin, altered mental status. Treat the physiology, not the cuff. Fluid bolus, 20 milliliters per kilogram of balanced crystalloid. Push it in over 5 to 10 minutes. Reassess. Repeat as needed up to 60 milliliters per kilogram in septic shock, but pause earlier if you see signs of fluid overload, like hepatomegaly or new crackles. Pediatric shock physiology is unforgiving. Cold versus warm pediatric shock. Cold shock, low cardiac output, high systemic vascular resistance, cool mottled extremities, prolonged capillary refill, narrow pulse pressure. Epinephrine infusion is the pediatric pressor of choice. Warm shock, high cardiac output, low systemic vascular resistance, flash capillary refill, bounding pulses, wide pulse pressure. Norepinephrine infusion. The board pearl, epinephrine for cold pediatric shock, norepinephrine for warm pediatric shock. Both still need source control and adequate volume first. Septic shock in older children often presents as warm shock. In infants, more often as cold shock. Look at the patient. Disposition and documentation. Every patient on a vasopressor in your ED, ICU admission. Step down only after the pressor has been weaned off and the patient has demonstrated sustained hemodynamic stability. If your facility cannot offer ongoing critical care, transfer. Document the shock category, the initial lactate, the fluid volume given, and the type, the pressor agent and rate, the lactate trend over time, the source control performed, the map target and when it was met, the peripheral pressor protocol used, critical care time spent. If the patient went on a pressor in your ED, it is critical care time. Document the minutes. Common ED pitfalls, the ones that hurt patients. 1. Waiting for the cuff to crash before starting pressors. The lactate already said yes. 2. Bolting a 30 milliliters per kilogram bolus into the cardiogenic shock patient with pulmonary edema. You will drown them. 3. Delaying intramuscular epinephrine in anaphylaxis while debating IV access. The thigh is right there. 4. Choosing dopamine because the central line is not in yet. Use peripheral norepinephrine. 5. Forgetting source control. 6. Missing right ventricular strain on the undifferentiated shock POCUS. Massive PE is the deadly miss. 7. Anchoring on one category. Many ED patients have mixed shock. The septic elderly woman with baseline diastolic heart failure who also dropped her hemoglobin overnight. 10 things you will not forget. 1. Shock is inadequate tissue oxygen delivery. A lactate over 4 or a base deficit more negative than -4 is shock, even with a normal blood pressure. 2. The MAP target is 65. Not 75, not 85, unless patient-specific reasons. 3. 4 categories. Distributive, hypovolemic, cardiogenic, obstructive. Know the systemic vascular resistance, cardiac output, and preload pattern of each. 4. Rush exam in 5 minutes. Heart, IVC, Morrisons, aorta, pneumothorax. Changes management in 1/3 of cases. 5. Balanced crystalloid is the default. Lactated ringers or plasma light. Save normal saline for trauma transfusion compatibility. 6. Septic shock, 30 milliliters per kilogram is a starting point, not a mandate. Reassess every 500 milliliters. 7. Cardiogenic shock does not get 30 milliliters per kilogram. Norepinephrine plus dobutamine. Cath lab. 8. Anaphylactic shock, intramuscular epinephrine in the thigh first. Fluid second. Antihistamines and steroids are adjuncts, not lifesavers. 9. Norepinephrine is first line for septic and cardiogenic shock. Can be started peripherally. Dopamine is the wrong answer. 10. Pediatric shock is normotensive until it isn't. Epinephrine for cold shock, norepinephrine for warm shock. Remember. Documentation pearls. The shock category. Name it explicitly. The initial lactate, the fluid volume given and the fluid type. The vasopressor agent, dose, and time of initiation. The rush findings. Chamber sizes, IVC, presence or absence of effusion, presence or absence of free fluid, presence or absence of pneumothorax, the MAP target and when it was met. The peripheral pressor protocol used, site, IV gauge, monitoring frequency, plan for central access, the source control performed, the critical care time spent, clean documentation is a clean shock case. Resolution. The 3 cases, each one lived because the framework worked. Case 1, our 78-year-old septic patient, 2 liters of lactated ringers, peripheral norepinephrine through a proximal IV while the central line was being placed. Vasopressin added when the norepinephrine requirement climbed. Foley catheter, urinary source control, broad-spectrum antibiotics within the first hour. Her lactate cleared by hour 6. Case 2. Our 64-year-old anterior STEMI in cardiogenic shock. No big bolus. Peripheral norepinephrine. Dobutamine added for the cardiac output. Cath lab activated. Percutaneous coronary intervention within 90 minutes. He survived. Case 3. Our peanut anaphylaxis. Intramuscular epinephrine, 0.3 milligrams in the thigh, repeated at 5 minutes. Stridor resolved, fluid followed. She went home the next day. 3 pathways, 1 framework, the same Rosen's algorithm under all 3. Next time you see one of these stems on a board question or a real patient, you know the move. Next time, cardiac arrest, recognition, resuscitation, post-arrest care, you ran the shock, the blood pressure came back, and then the monitor flatlined. See you there.